So I will, as Dr. Ramirez mentioned, be giving us a quick overview of C. difficile infection today. So the first thing for us to talk about is just the overall burden of C. difficile infection. Primarily in the hospital, we really worry mostly about our hospital onset infections, but this report from the CDC on antimicrobial resistance overall is all encompassing of both hospital and community onset disease. So that report rated C. difficile as an urgent threat, which is the highest level threat the CDC assigns to any multi-drug resistant organisms. So it's in the company of things like carbapenem resistant gram-negative infections. In 2017, they estimated that C. difficile was responsible for greater than 200,000 hospitalizations, nearly 1,300 deaths, and $1 billion in healthcare costs. So the overall burden of this somewhat preventable illness is very significant across the country. Not only that, but the other piece for us to consider is the quality of life of our patients with C. difficile. So if you've had the pleasure of learning about C. difficile, the illness involves colitis and profound diarrhea. So it's quite really burdensome for our individual patients as well. What I wanted to share was this study that was a survey of patients who had been hospitalized with C. difficile and then recovered and had been discharged home. What they did then is conducted two different quality of life surveys, one which was more generalized and one that was more specific around information with C. difficile infection, which is the C-diff 32 survey. So based on the respondents, which was about 120 patients, they found that those patients had, even after they had recovered, were rating themselves as lower on physical health as well as mental health relative to the general population, and that even lower scores were associated with patients who had had recurrent C. difficile illness, more severe illness, and additional stool episodes per day. So with that, what we can probably glean from this information is even after our patients have recovered, C. difficile does seemingly continue to impact their quality of life in a negative manner. So in terms of risk factors for C. difficile, the guidelines note a couple different things, including advanced age, hospital exposure and length of stay, irritable bowel disease, immunocompromising states, end-stage renal or liver disease, antibiotic use, and proton pump inhibitor use. The unfortunate thing about most of these risk factors is they're not necessarily modifiable. For instance, we can't just age in reverse and go back to being younger. But one of the things that we can manage is certainly antibiotic use. And that's where I'll be spending the bulk of the discussion a little bit later on. So when it comes to a patient actually getting C. difficile in the first place, a couple different things actually have to occur. The first would be exposure to the C. difficile organism via the oral fecal route. And that's how C. difficile actually makes its way into our normal flora within our GI system. Next, we have to see disruption of that GI normal flora, which is typically via antibiotics. And once we've got that disruption of the normal GI flora, we may see an overgrowth of C. difficile. And if the patient's own immune response isn't adequate enough to control for that overgrowth of C. difficile, that's where we'll see the progression to diarrhea, colitis, abdominal cramping and pain, and in very severe cases, ileus, septic shock, toxic megacolon, and maybe even death of the patient. So the first thing that we may actually be able to modify with this would be exposure to the C. difficile spore. So I will touch briefly on infection prevention. I say briefly because this isn't my exact area of expertise, and because frankly, I'm a little bit intimidated to be lecturing to Dr. Carrico about it, given that she actually wrote the guidelines on this. So what I will mention is that C. difficile is particularly challenging from an infection control standpoint, given the spore-forming nature of the organism. Those spores are pretty hardy, and they tend to be resistant to alcohol-based hand sanitizers, which is what we typically use as we're moving in and out of patients' rooms in the hospital. So if those spores are stuck to somebody's hands, the alcohol doesn't kill them and they go on to the next patient room, then those spores can relatively easily spread from one patient to the next. Therefore, it's recommended to wash our hands with soap and water in an effort to reduce that spore transmission when we're taking care of known C. difficile patients. However, since this isn't part of our normal practice with most of our patients, if we have a patient we're not aware that they have C. difficile yet, we may actually see significant spread of those spores throughout the hospital before we make that diagnosis. So coming back to our disruption of normal flora, the next thing for us to consider is how we might think about those things. So I just wanted to illustrate what this can actually look like. So this is our healthy GI tract that has normal flora in it. These are our what we would call probably good gut bacteria, so things that we generally live in harmony with. But let's say that a patient ends up contracting some degree of C. difficile colonization. So they've ingested some of that organism and now it's within their GI tract. The game changer is when we give an antibiotic and we kill off some of that good normal GI flora. And essentially what we've done is opened up real estate that if C. difficile wants to move into, it has that opportunity. So not every patient who gets an antibiotic is going to end up with C. difficile infection, but essentially what we've done is prime the system to allow for that opportunity should C. difficile potentially overproliferate. So it just puts us at risk. That being said, not all antibiotic risk is created equal. So we'll go ahead and discuss that in a little bit further detail. So this study actually came out nearly 10 years ago and was published in Clinical Infectious Diseases, but it still would inform a lot of what we know around antibiotic relative risk and the likelihood of a patient contracting C. difficile. So this study specifically looked at patients who had gotten antibiotics in the hospital and their likelihood of getting a C. difficile infection confirmed with a toxin result 60 days after hospital discharge. The first thing they looked at was overall antibiotic length of therapy. And just one caveat about how they measured this. This was in defined daily doses. So what that means is if a patient was getting 2 antibiotics on a single calendar day, that counted as 2 days of therapy. So just a caveat in how we're looking at this information. They used less than 4 days of therapy as a reference, but for every 4 to 7 days of therapy, the risk of C. difficile was 1.4 times higher. 8 to 18 days, our risk was 3 times higher. And if patients received greater than 18 days of therapy, the risk was 7.8 times higher. So essentially what we see is probably longer durations of therapy, more disruption of that GI flora, more opportunity for C. difficile to actually come through and cause an infection. The next consideration was the cumulative antibiotic exposure, given like the number of drugs. So they used 1 drug as a reference, but if the patient was treated with 2 different antibiotics, the risk was 2.5 times higher. 3 to 4 drugs, the risk was 3.3 times higher. And if a patient were to receive a staggering greater than or equal to 5 number of drugs, then the risk was 9.6 times higher. So oftentimes when patients come to the hospital, we will start them on multiple antibiotics. And that's what we would refer to as broad spectrum, because we're trying to make sure that we cover everything that possibly could be causing an infection. But then as we get more information, more patient history, our culture results come back, we really nail down exactly what's going on with them. This would highlight the importance of narrowing down our therapy and getting onto a single drug if possible. Essentially what we think there is the more agents we're using, the more bacteria we're killing in the gut, and the more likelihood that we're giving C. difficile an advantage in that scenario. So then the last piece of this study was looking at the particular antibiotics that patients actually received. And when it came to C. difficile risk, the #1 spot was taken by our fluoroquinolone antibiotics. We did also see significant risk with cephalosporin antibiotics, specifically 3rd and 4th generation cephalosporins, so things like ceftriaxone and cefepime. So all of the antibiotics certainly can put our patients at risk, but quinolones seem to be one of the things that pop up in multiple studies as being a particularly high-risk antibiotic. That's one of the reasons that they tend to be a target for a lot of antimicrobial stewardship programs around the country. So I wanted to share one of those studies with everybody. So this was a study done by Katie Shea down in Texas and was a multi-center quasi-experimental look at 4 adult hospitals in Texas. So this one actually had 2 different phases. The first was provider education, where they went out and talked about the risk of C. difficile associated with fluoroquinolones. This included their hospitalists, their ER physicians, their pulmonologists, seemed to be relatively widespread across everybody who was taking care of patients in the hospital. The second phase was fluoroquinolone restriction. So they specifically laid out criteria where providers were allowed to use these quinolone antibiotics. They had a couple different ones, but mostly were focused in community-acquired pneumonia patients. So in those patients, they allowed for quinolone use in severe beta-lactam allergies if that patient had received a cephalosporin within 3 months leading up to their hospitalization, so potential concern for treatment failure or resistance in that scenario, or if a patient had a positive Streptococcus pneumoniae culture with an isolate resistant to ceftriaxone. So as I mentioned, they had a couple other allowable criteria, but they tended to be pretty niche. So we'll mostly just focus on the community-acquired pneumonia patients in that scenario. Here were their results though. So what we have here is the fluoroquinolone use in days of therapy per 1,000 patient days, and then their number of hospital onset C. difficile cases per 10,000 patient days. In our pre-intervention phase, we had around 41 days of therapy for our quinolones, and after the provider education, this decreased to 21.5. Similarly, we see a higher rate of CDI cases at baseline, and then a slight decrease in our CDI cases per 10,000 patient days after that provider education. And this was actually statistically significant. Then they moved to their next phase, which was that actual restriction. And we actually see from that point almost a 90% decrease in our quinolone use and about half of the number of cases of CDI. So I like to mention this study just because I think it's interesting that they utilized 2 different modes to try to actually decrease that prescribing, but you can actually see that seemingly that there may have been some effect based on both of those interventions. Now here at Norton, we really do not overall use restriction criteria in our stewardship program. We primarily use what we refer to as guidance criteria. So we'll put clinical decision support in EPIC where we try to steer people towards using antibiotics in a way that we think is appropriate. And then the other strategy that we primarily use is prospective audit and feedback, which is basically just a fancy way of saying that the ID pharmacist will review patients and then make recommendations to providers if we think that there's an appropriate de-escalation, adjustment, and therapy to be made. So this is actually our quinolone use at Norton over time. So utilizing slightly different strategies, but I would argue seeing similar results. So we have back in 2016, our quinolone use up here around 80 days of therapy per 1,000 patient days. And through 2020, dropping down towards about 20 to 30 days of therapy per 1,000 patient days. So this has definitely been a target for our stewardship program as well. But as I mentioned, we've taken a slightly different strategy based on what we think works here in our healthcare system relative to that previous study we talked about. So here at Norton, we're not just worried about quinolones. We do try to take a relatively holistic approach when it comes to reducing these high risk for C. difficile antibiotics. If you've been on any of the stewardship calls, you've seen this chart before, but for anybody who it might be new to, I'll just go ahead and orient you. So on our y-axis, we have days of therapy per 1,000 patient days. We like using this metric to track antibiotic use because it somewhat normalizes out for changes in census over time, as well as helps us control for the different sizes of the hospital so we can more accurately compare our 4 institutions. Then we have Norton Hospital, Ottoman Hospital, Women's and Children's, and Brownsboro in these clusters. And what we have is starting in 2016 and then moving through year to date of 2021, our antibiotic use. And this is a composite of our fluoroquinolones, ceftriaxone and cefepime, meropenem, and piperacillin tazobactam. So antibiotics that we could consider to be relatively high risk for C. difficile. So what you can see over time is some nice trends down in overall antibiotic use that puts our patients at risk for C. difficile. And that's certainly something that we're proud of, but something that the stewardship program is continuing to work on. We will never reach a point where we're not using these antibiotics at all. That's simply not realistic. We can't make our risk of C. difficile in our hospitalized patients 0. But what we can do is try to get it a little bit closer to an optimized state. And one of the ways that we can do that is utilizing some of our lower risk antibiotics. And I use the term lower because it's not no risk, but it does help mitigate some of that damage to the GI flora. So on this list, we have things like penicillins, which are thought to be potentially somewhat protective against C. difficile, since they seem to, at least based on lab information, have a little bit of activity against C. difficile. So potentially might help control for some of that overgrowth of that particular organism. Other things would be first generation cephalosporins, tetracyclines, nitrofurantoin, which we use in treatment of uncomplicated urinary tract infections, metronidazole, aminoglycosides, and vancomycin. So the thought here is that all of these just do a little bit less damage to our GI flora overall. And if we can help maintain some of that healthy GI flora, we give less of an advantage to C. difficile. So the last couple things I will mention here is around diagnostics and treatment. So C. difficile testing is something that Dr. Junkins can definitely speak to in more detail, but I'll just give a brief overview. Here at Norton and at most hospitals, we would only recommend to test patients who are having clinically significant diarrhea. So this would be greater than or equal to 3 unformed stools per day that are new, and we don't have another explanation for why that's happening in our patients. Here at Norton, we utilize a 2-step algorithm. The first test is a PCR test, which actually detects for the DNA of the C. difficile molecule. Or organism, excuse me. This is the more sensitive of the 2 tests, but it can be less specific to active disease. So we looked at how our antibiotics, or C. difficile, excuse me, may actually colonize our gut. So what we'll do here is potentially pick up colonization based on that PCR test alone. The toxin assay is less sensitive, but can be more specific to actual active disease. So once C. diff is actually proliferating and causing colitis, usually that toxin is actually present, and that's what's causing some of the inflammation within the colon. So the possible results that we could get based on our testing algorithm is a PCR negative test. And if the PCR comes back, we don't have any C. difficile DNA there, we're just going to say that the patient does not have C. difficile. Next, we could have a PCR positive and a toxin negative result, which could mean that the patient is colonized or may actually have active disease. So this requires a little bit of clinical interpretation. That being said, if that patient is having diarrhea, it's new, and they're having systemic signs and symptoms of infection, so things like fever, elevated white blood cell counts, then I would definitely say that patient probably does indeed have C. difficile, despite that negative toxin result. And then the last is PCR positive, toxin positive, in which case all signs are pointing towards C. difficile, and we're going to say absolutely that patient has a C. difficile infection. So lastly, I'll just briefly touch on treatment of C. difficile. It's primarily driven by the severity of illness as well as how many occurrences of C. difficile that the patient has actually had. Our treatments are typically going to be oral vancomycin or oral fidaxomicin. And once we start getting into recurrences, we might start thinking about prolonged or tapered oral vancomycin, so a longer course of therapy. At that point, we may also start thinking about things like bezlotoxumab, which is a monoclonal antibody. It actually binds one of the types of C. difficile toxin and has been shown to potentially reduce some recurrences, particularly in patients who are greater than 65 or have immunocompromising conditions. The last thing that we may consider in patients who are having multiple recurrences would be fecal microbiota transplantation, or FMT, which is essentially we are saying that this person's GI flora are really just shot at this point, and we need to see if we can essentially reset. So what that involves is getting donor stool, which will be screened for C. difficile, and then administered to our patient, typically via colonoscopy, to help repopulate their colon with healthy GI flora. And obviously this is quite a bit more invasive than any of our oral or IV treatment options, but it does have very high success rates and can be a good option in patients, particularly who are struggling with these multiple recurrences. The last thing that I'll just mention is fulminant disease, where we have patients who are in septic shock or hypotensive. We will dose more aggressively with our oral vancomycin, and we may consider adding on rectal vancomycin or IV metronidazole, particularly in patients who might have an ileus, and we think that we're struggling to actually get our oral vancomycin to the colon, the site of infection. So that concludes my overview of C. difficile. What questions can I answer?
Very good. Thank you very much, Sarah. Great overview. And we can open the forum for questions or comments.
Sarah, so I guess, Sarah, one of the questions that I have is, so what has been the impact on the program regarding the rate of C. difficile infection that within the hospital? So that would be the healthcare associated infection. I know that I see a number of the infection preventionists on the call, and it may be interesting then to get some of their comments about how this has worked in practice, because we think about the stewardship programs. This is what I always think of as the holy trinity. Here we've got overlap with pharmacists, and we have overlap with the healthcare epidemiology program, the ID physician, the IPs, and then also with microbiology. So how successful has this approach been in reaching the desired outcome of reduced rates of disease? Sure.
So definitely, if anybody from IP would like to jump in, please feel free as well. But I can tell you that overall, we did see a significant decrease, particularly when we actually changed our testing algorithm up a little bit in 2019. So that was shortly after I joined here at Norton. We did see quite a bit of decrease, about 50% from 2019 to 2020. We have seen some uptick in our C. difficile rates through 2021, particularly actually at Audubon Hospital. One of the things that we have noted with that, though, is that Audubon continues to be highest in its use of these broad spectrum antibiotics. So obviously, IP plays such a huge role in this as well, and I don't want to dismiss the importance of those practices. But one of the things that we've really been pointing to at Audubon is to say, if we're seeing these higher rates of C. difficile and these higher rates of antibiotic prescribing relative to all the other hospitals, perhaps we need to revisit some of our prescribing. And I think that we can hopefully try to minimize some of that pressure that we're seeing here at Audubon through 2022.
Yeah, Sarah, this is Julia. I guess, Ruth, to answer your question, overall, our SIR is, from a system perspective, from 2020 to 2021. So it was 0.52 in 2020, it's 0.51 in 2021. So from a system perspective, below what is expected and arguably fairly lower than what is expected, right? To Sarah's point, Audubon has the highest SIR of the system at 0.74. So still below what is anticipated or expected, but higher than everybody else. I guess my question would be around the restrictions process. So we have guidelines or suggestions as it relates to the quinolones. Has there been conversation or discussion, I guess, about going to the restriction methodology, right? It seemed like it was successful. And then the other question that I would have is, when we look at the number of antibiotic days, prescribed days per, I guess, 1,000 patient days or prescribed, what is our goal? So is 200 great? Like, fantastic, we've hung out in the low 200s for 4 years and we're doing what we should be and we're at goal? Or is it above goal, but better than where we were, and so we're making great improvement?
Mm-hmm. Both excellent questions. The first one is definitely going to be a little bit easier. So we have talked about restriction criteria That being said, it's not something that as a stewardship program, we feel really great about pursuing at this point. Where restriction criteria, at least in my opinion, really fit is when you're probably understaffed to actually review patients on an individual basis. So what we've done here at Norton is add a lot of antimicrobial stewardship pharmacists with the idea that we will provide more individualized recommendations on those patients. It's not perfect by any means. Whatever methodology you choose, there's going to be some of those limitations, but I think that really trying to individualize our recommendations, since we have the resources to do it, is probably the way that we will continue to go. On the second part, as far as what is optimal, the short answer is I couldn't tell you for sure. The longer answer would be, I know that we're not there yet. So we all continue to have jobs on the stewardship side because we haven't totally figured out the exact right way to use antibiotics as a society overall. So the stewardship pharmacists could all tell you that from reviewing patients on a day-to-day opportunity, we do still have those opportunities, but where we'll probably start to really see a signal in the data that we're approaching what we would consider to be optimal is whenever we start to see that curve kind of plateau off. And once we're saying that we're using a pretty consistent number of these antibiotics, we're not finding lots of opportunities to change them. And when we don't continue to see that downward slope, that might indicate to us that we're starting to approach that optimal use of those broad spectrum agents.
Do we, just a clarifying question, I guess, do we submit to, or I think we do submit some antibiotic information to NHSN?
Yes.
Do they have rates or ratios or expectations, and where do we fall with them?
Yes, so they do have benchmarks similar to what we see with the C. difficile rates. Based on that, honestly, our antibiotic prescribing looks reasonably good overall. The caveat with that as well would just be that we're compared to peer hospitals. And if we believe that we continue to have opportunities, just because we're doing better than other people does not mean that we should necessarily just rest on where we're at. So it definitely is encouraging to see benchmark data and say, okay, hey, it looks like we're continuing to make progress and we look like we're in reasonably good shape against some peer hospitals. But like I said, since the stewardship pharmacists are doing this work on a day-to-day basis and looking at those individuals, we do want to continue to push on opportunities when we're seeing them.
I may say that as Sarah mentioned, if you were to have an antimicrobial stewardship program that is able to evaluate most of the antibiotic use, probably the goal is the pharmacist perform a recommendation. And then the question is, what percentage of your recommendations accepted? Then this is going to be your goal. Mm-hmm. Then if you have your, as we discussed last time, you have your process control, and of course nobody expects that you're going to have 100% of the pharmacy recommendation accepted, but you are above 90% acceptance every month. You may say, well, we are there. Now, this doesn't mean that you don't need the antimicrobial stewardship, because the question is going to be how many times you need to make a recommendation. And usually I see numbers in the literature that if you have a good antimicrobial stewardship program in every hospital, probably 50–60% of the antibiotic use will be in compliance with all the guidelines. Then you always have 30–40% that are a little bit out of touch. But then the antimicrobial stewardship made recommendations and the physicians accept the recommendations, that you go to above 90%, then you think I'm reaching a goal. Then the antimicrobial stewardship is there to improve this 30–35% antibiotic use. And this is going to be the important thing. Now, Sarah mentioned that for CD, there's always, she mentioned the first step, colonization, the second step, antibiotic use, but the third step is always the immune system of the patient. Then you're in a place that you have a lot of immunocompromised patients. Well, you can still have a optimal infection control program, an optimal antimicrobial stewardship program, you still are going to have CD. I mean, I don't believe, as some people say, that you can be in a hospital with very complex patients and you're not going to have nosocomial healthcare associated infections. But I may say that as long as you are above 90, some people say 95%, you follow the guidelines, you are in the optimal. But at the same time, and I think that Sarah alluded to this, if you want compliance from the medical practice, reaching 95%, you cannot have too many essentially rules that you cannot do this, you cannot do that, because you want every medical staff, but really every medical staff should be part of the antimicrobial stewardship team. They're saying that every medical staff should be part of the infection control team. If you want every medical staff to be part of the team, you cannot treat them badly because they're not going to be part of the team. Then this is why probably, and I like the idea, restrictions, if you don't have enough people to do prospective surveillance, well, you just do restrictions. But you want the medical staff to accept recommendations. Restrictions are not a good point. But do we know, Sarah, how many from the antibiotic use in different hospitals at the end of the day, from 100% of the use, do we know what percentage is according with your guidelines, according with the antimicrobial stewardship guidelines?
No, and that's something actually that we were talking about as a potential research project. Obviously, that involves quite a bit of labor to actually figure that out. But yes, I would say that at this point, we're not totally confident on how much we are sticking to our local or like IDSA guidelines.
Very good. Any other comments or questions regarding this topic? Well, this was an excellent review. We are going to continue with this idea of having topics related to infection control, antimicrobial stewardship, and as an overview, the next this coming Wednesday at noon is going to be an overview of a hospital program to control multidrug-resistant organisms. There is a little bit of controlling multidrug-resistant organisms in healthcare setting. There is a little bit of what we are discussing today, the interaction of infection control, antimicrobial stewardship, and the medical staff. Well, thank you for your attendance, and then I'll see you this coming Wednesday.